So I'm greatly honored at the invitation to be amongst you today, especially because this wonderful society of physicians also happens to be for the first time that I've been asked to speak to general physicians. You know, I've done hundreds and hundreds of talks over the years in various fora, but pediatricians generally don't have a big voice in national fora. And I am therefore extremely honored at the opportunity to speak to you today. The topic that I will cover today,
I'm greatly honored at the invitation to be amongst you today, especially because this
academic fora in Pakistan, and because there isn't much recognition of the whole issue of what health equity represents. So what I will cover in my talk is really why should we be doing this, what were the lessons from the Millennium Development Goals globally, and particularly the implications for Pakistan. I'm going to spend a little bit of time on measurement, exactly how our research group has worked over the years in trying to get a better granular understanding of what health inequities are in various parts of the world to make the invisible visible at a policy platform. And then, of course, I will spend a fair amount of time on what strategies are there that can make a difference, and are there any innovative approaches within Pakistan that give us hope that we could also make a change. And finally, I hope to talk a little bit about what you, as the Pakistan Society for Internal Medicine, could do as we move forward. So let me step back close to around 20 years ago, 21 years ago to be exact, when some of us met in this scenic Rockefeller Center at Lake Como, the so-called Bellagio Center, to consider what was happening to the world of child survival. This was the time when UNICEF had had major transition with Jim Grant having passed away, and a lot of global recognition of progress around maternal child health having slowed down had sunk in. We got together in this center to spend some time and to come up with the first Lancet series in global health that looked at child survival, the so-called Bellagio Child Survival Series, which made several points. And I'm only going to point out two to you today. One was perhaps one of the most influential infographics ever produced in public health. This map was our estimation of where 10 million children were dying every year in the year 2000. Each one of these dots represents a cluster of 10,000 deaths. And as you can imagine, they're largely clustered in two geographies. They're clustered in Africa and in South Asia, which because of its population density appears as a red blob. But we also produced something else. We produced a document to say that we knew sufficiently in terms of evidence-informed interventions that we could save close to around 2/3 of all these deaths as we stood, provided we could implement them at scale. And that was one of the reasons why around that time, when these Millennium Goals, which were set in the year 2000 with 2015 targets, were floundering, that we particularly focused on how you could address Goal 4, which was to reduce child mortality by 2/3 by 2015, and Goal 5, which was to reduce maternal mortality by 3/4 by the year 2015. Now, it's very rare that academic or research enterprises have an impact by themselves. But there was something that this Bellagio Child Survival Series did that really rejuvenated a lot of interest in countries that they could indeed do the impossible, that they could accelerate progress and make things happen. At that time, we were not aware. But now when we look back and see what actually happened in the decade that followed, you can see that from a baseline figure of close to around 12.7 million child deaths in the year 1990, the base figure, which had only gone down to 10 million by the year 2000, that we were able to accelerate child mortality reduction worldwide to under 6 million deaths by the year 2015. And if you take the increase in global population into account, the world actually, ladies and gentlemen, achieved Millennium Goal 4 of reducing child mortality by 2/3. This was the fastest rate of reduction of child deaths in the history of mankind. Never has humanity ever got together to reduce the global burden of an atrocity or an injustice like child mortality to this extent. And it was only made possible through a spirit of collaboration, cooperation, and evidence-informed policies. But let's disentangle this a little bit as I make the case for why we missed a few things. First of all, we recognized soon afterwards that progress was not equal across the world, that this global average mortality reduction was largely driven by a few geographies. It was driven by China, it was driven by Brazil, and it was driven by some progress in Middle East and Eastern Europe. But for a large number of countries in Africa and in South Asia, the progress was suboptimal. And the person who absolutely hit the nail on the head in recognizing what this meant was none other than the executive director of UNICEF, Tony Lake, who within a couple of weeks of his taking over, actually made this statement in the year 2010. And I picked it up because it was such a profound statement. And he said, behind these statistical national successes, we masked tremendous moral and practical failures. Because we leave behind those averages people who are actually left behind on the basis of where they live, who they are, whether they're in conflict zones, indigenous populations, or people with disabilities. Let me try and illustrate this with an example, again from the MDG period. So this particular cartoon shows on the y-axis whether countries had increase in inequality in child mortality or a decrease in inequality in child mortality, and on the x-axis are whether mortality reduced or increased. So what you see in this top quadrant are a large number of countries where actually, although mortality went down, but the inequality in mortality increased. And a lot of the students don't understand, sir, how can this happen? Of course this can happen. It happens in the world of economics all the time. A national GDP per capita income can be just pulled up because you have 1% of billionaires. India is a current example at the moment. But because you miss out many of those averages and figures you do not capture in the national averages, the entire range of what can happen. And that brings me to the difference between inequality and inequity. And it's a very important difference. We use these terms often interchangeably, but they are very, very inherently different. So health inequities represent systematic differences in health status and distribution of resources in different population groups, which are largely a result of social determinants or the fact that people are born in certain conditions that they cannot grow out of. While inequality represents differences between individuals and population groups, inequity represents differences which are avoidable, unnecessary, or unjust. So in one simple term is inequities are unfair inequalities. And if you can remember this, then you will understand the difference between inequality. पांचों उंगलियां बराबर नहीं होती. We don't have similar conditions, and many people live in rural areas, many people live in urban areas. Even within cities, people have different living conditions. But where that restricts and constrains human development because you have unfortunately restricted the opportunity to grow out of that or to have access, that's where it is called an inequity because it's unjust. If a poor person's child can never have the hope of good education and to improve his or her want in life, then that's an unjust inequality. So that's a very important fundamental difference, and it is behind a lot of the social deprivation and human development impediments across the world. Now, what are the drivers of inequities? There are three major drivers, and very quickly. They are structural, which are based on public policies, institutional practices, etc. In the US, for a long time, these structural inequalities were why African Americans could not get into higher education. Because on an open merit basis, you just could not get in. They're also based on social factors, things that relate to income levels, employment status, gender, ethnicity. Ethnic groups have not the same opportunities for growth. And then there are fundamental unequal distributions of income, power, and wealth that are based on, at times, political considerations. So just to round up this part, if you want to understand the difference between equality and equity, this graphic will just tell you this. This is the reality of how unequal many things are, but then how you can make them equal by deliberate interventions to provide access to people irrespective of their constraints. Okay? So let me now turn to how does this relate to Pakistan? Can we measure inequalities? Can we measure inequities? And I'm going to use, I'm a pediatrician who works across maternal and child health, so shamelessly I'm going to use examples from my field, maternal and child health. So the data that we have on maternal and child health is largely from household surveys in Pakistan. And if you look at child mortality trends, we've had a reduction in child mortality over time. But the corresponding reduction in newborn mortality has been much slower. So if you look at those rates of changes over time, they are close to around 1/3. Newborn mortality reduction is only 1/3 of child mortality reduction. But it is about 50% of the total burden of under 5 mortality. And a lot of this mortality is related to maternal conditions. If you look at the first day of life, ostensibly the happiest day in the life of any individual or family, it is also the saddest day in the life of many, because a lot of these maternal and newborn deaths are clustered within that 24-48-hour period. And for Pakistan, close to around 350,000 babies and mothers die in that 24-hour period on the day of birth. And that is currently still, despite all our efforts, invisible in the policy framework. Because if it was invisible in the policy framework, that's why it would not translate into measurements. Somebody should produce a report every year to say how many mothers are dying within 24 hours of birth, how many babies are dying 24 hours of birth. But the world does not have to depend upon the government of Pakistan's statistics. The world has its own ways of measuring. And sadly, at this point in time, if you look at the rate of reduction of newborn mortality in Pakistan, in comparison with not the world, but our neighbors in the region, we have the lowest rate of reduction in newborn mortality. Actually, shockingly, even behind Afghanistan. Now, admittedly, Afghanistan has some issues with population measures, but where there are measures, they have generally done better than us because some of their populations are actually much better in terms of primary care than we are, because they have a system. And if you were to go beyond our region and to look at the globe and say, if you take GDP per capita income and neonatal mortality rates in comparison, so here you have on the x-axis GDP per capita income and on the y neonatal mortality rate, I don't have to tell you where Pakistan is. For the last 10 years, we have been at the top of global neonatal mortality ranking. Now, my dear friend, the Honorable former Minister of Health of Punjab is here. Sir, I don't think there has ever been a recognition of this sad statistic at the level of, I will not say the government, any political party in Pakistan. For some reason, Imran Khan was made aware of stunting, so he put that up. But neonatal mortality is the greatest scandal in this country, and it has not changed for almost 30, 40 years in any substantive way. And when we are confronted with this statistic, particularly because of the work that I do in this area, first question people ask is, why haven't things changed in Pakistan? So let's examine now for a minute why things have not changed and why are we constantly talking about measure metrics and indicators around this. So let's look at some of these causes behind the causes. So of course, poverty is a very big measure. But poverty is a complex measure. Poverty is much more than income or assets or how much money do you have in your pocket. Poverty is also about how much services you have access to, hope, hopelessness, and your opportunities, as I had mentioned, both in terms of being able to lift yourself out of poverty and to improve your life. In 2007, when we did the demographic and health survey, my team was very much part of looking at the etiology analysis. There was a question in there to ask husbands and wives, had they made preparations for delivering in a hospital or put money aside for a childbirth. And amongst the poorest quintiles, 70% of the husbands and wives had not even bothered to either number one, make financial arrangement, or even consider that they could deliver in a better facility. Because for many people, agar hum dehat mein paida hue hain, to dehat mein hi marenge. That is the situation that poverty brings at times around what we call poverty of hope. So we have a different measure of poverty, what we call multi-dimensional poverty index, which is based on several measures: education, living conditions, GDP per capita income. And we've estimated, not just us, many others, including PIDE here, the MDPI, the multi-dimensional poverty index, for various parts of the country. And as you can see, many parts of the country have multi-dimensional poverty indices which are just as bad or even worse than Africa, notably parts of southern KP and Balochistan. And there is a very close correlation between health services. I've only put one indicator here, which is skilled birth attendance, and that multi-dimensional poverty index. So it is these places which have virtually nothing. They have no services. They have people living in far-flung populations who have very little access, very little innovation. And therefore, it's hardly surprising that in many of these places, they are far, far removed from national averages. And I want to show you one more statistic that people don't generally talk about, or talk about honestly, which is what have we done as a nation in the 70-plus years that we've been here for human resource development for health. We are all physicians here, more or less. So we're all very happy that Pakistan has produced a large number of physicians over time that you see in the top graph. But look at the difference between that and nurses and midwives. Has anybody even registered that in the last 5 years, particularly since the economic downturn and COVID, that we've actually hemorrhaged nurses from Pakistan? That our numbers have gone down substantially? The only group of people that we have as ancillary workers that supports our primary care program are the lady health workers in blue. This program that I work very closely with was started by the late Shahid Benazir Bhutto because she wanted to do something for primary care in the poorest parts of the country. It grew, and then after devolution, the provinces took their hands off it. Punjab declared it a dying cadre of individuals, and their numbers slunk, and they've only just begun to climb up. But you're not going to sort the problems of this country through physicians only, especially when you have this. Almost 90% of all pediatricians and obstetricians of Pakistan are in the provincial capitals. I have put this figure out on the basis of periodic assessments that I've done over the last 20 years, and this sadly remains the case. There is some trickle down, but it's generally not of the specialists. They're of diploma holders, lower level cadre of people. So if the bulk of all of this is going to be in the big cities, then we are not going to be able to handle the reality of the entire country. So what is the reality of the entire country? And I want you to understand this, and I want you to remember what I mean by this overall statement that we live in 5 Pakistans. The 5 demographics of Pakistan are based on our assessment of inequities. Number one, we know that there are differences between the rich and the poor. So the way we look at coverage for many children interventions, immunizations, is to look at the differences between the poorest and the richest. And you can see that there is a gap. The rich have more, the poor have less, the coverage of interventions. But this gap is widest for maternal health. So it's particularly around childbirth and maternal health that these gaps emerge tremendously. Now, there is another way of looking at it. The problem with this is you don't know where the poorest quintiles are, where the richest are, where are these people. So you can look at this by districts. So this is something that we developed in Countdown. It's called a Manhattan plot, which looks at coverage range of interventions over time. In each one of these dots, ladies and gentlemen, is a district of Pakistan. So ये Pakistan का data है from 1990 to 2018. Each one of these is a district of Pakistan. And the point is that even though we may have improved overall, the gap in districts and differences is huge. even for things like immunizations, which are a vertical program. And if you were brave enough, and again, I say we normally don't do it at a policy level, the government does not generate these statistics, because maybe it's politically sensitive, but when you generate these statistics on coverage by geography, you clearly realize that we live in 5 epidemiological zones in Pakistan. So I can show that to you by any indicator that you look at. There are 5 patterns for things like family planning satisfied, antenatal care, skilled birth attendance, full immunizations of children, simple things like diarrhea treatment, oral rehydration therapy, care seeking for pneumonia, so on and so forth. So there are parts of the world, like where we are sitting right now, where living standards and conditions are as good as I would have in Toronto. But there are other parts of the country where living standards and conditions and services are worse than what we have in parts of sub-Saharan Africa. Or till this does not become part of the policy imperative that we have to bridge this gap, and we have to measure this gap as a marker of progress, we are not going to be able to make change. And then there are 2 other painful statistics that you never see in official documents. And they are gender inequalities. So I'm only going to show you 2 figures, and then I want to move to what can we do. So gender inequities are rampant, but they are generally brushed under the carpets. Now, what gender inequity I'm talking about? Let's take 2 examples. This is Sindh. Rates of full immunization for children. The darker bands represent when boys are more immunized than girls. And remember, this is not newborns. These are now children up to 5 years of age. Okay? And this is, the difference here is about 30 to 40%. So it's not that there are differences. What I want to show you is, between 1990 and 2018, how little has changed. There are still districts of Sindh where this difference remains. Unless people think that it's only Sindh and Balochistan and other provinces where these differences remain, let me also show you a trend in Punjab, our richest province. This is the data on marriages of girls under 18 years of age. And you can see that there are parts of Punjab where that proportion has not changed for decades. So these gender-related issues are also underlying many of the problems that we face in Pakistan. Let me now accelerate and talk about what can we do. So in general, across the world, in order to reach these poor populations, there are several strategies that can be done at scale. And there are broadly 4 categories in here. One is that you can reduce poverty-related social determinants through safety nets, social safety nets. You can create demand and increase outreach for poor populations where there are no doctors, no other services, through ancillary health workers, community health workers. And in Pakistan, we are fortunate because we have the Lady Health Workers Program. That's one example. You can link communities to facilities through some kind of facilitation. And you can, of course, measure and monitor change because it helps guide you what is happening. So let's take some of these examples. Is there any example in Pakistan that you can improve outcomes by addressing poverty barriers and through strategies such as cash transfers? I hope the audience is aware that one of the largest, most innovative cash transfers programs for the poorest communities is in Pakistan. The Benazir Income Support Program. Again, you know, Benazir Bhutto's name comes again and again and again. Because, and I have no connection with her party, but I can tell you it was a woman prime minister who had the pain in her heart of what was happening to the women, and particularly poor women. So not only did she start the Lady Health Workers Program, but she started, or at least sowed the seeds of the income support program that targets the poorest women heads of households. So this has been there for a while, and we have been involved in some of the evaluations, but I'm going to tell you today the impact of this income support program on something that people are not aware of. So let's take stunting, one of the biggest challenges in Pakistan. And it's a problem which is not uniform across the country, although rates are high. So you can see between provinces there are differences. But much of the highest rates of stunting are in the south of the country. And we were very interested to see, are there differences in progress of stunting rates across Pakistan? And yes, of course there are. There are some parts of Pakistan that, irrespective of poverty, have done much better in reducing stunting. And we were very surprised. My own province of birth, and where, I've spent half my adult life, my brothers are here from Khyber Pakhtunkhwa, I come from Peshawar. You can see that the rate of reduction of stunting in Khyber Pakhtunkhwa is the fastest amongst all the provinces of Pakistan, 2.5%. And it's not a rich province. So how did this happen? And you can see this very clearly geographically when you look at stunting change between 2011 and 2018. This is based on geospatial data of district level specificity. So we did what is called a decomposition analysis to look at drivers, and we had data at meta level as to what has contributed to that change over time. And two things jump out. One is this big piece up top is economic improvement in general. So the province has improved economically. But look at this, 22% of the change that is attributed to stunting reduction in Khyber Pakhtunkhwa and in parts of Punjab is related to the Benazir Income Support Program. So these social safety nets not only remove poverty, they also address health and other inequities. What about outreach and community-based solutions, community health workers? So, my group's been working on this for 20 years. We've done the global assessments for this for WHO. We've published Cochrane reviews. We've looked at Global Health Workforce Alliance. And the bottom line in all of those is that if you take for newborn outcomes, the contribution of community health workers to neonatal mortality reduction, they have huge benefit. And they can certainly make a tremendous amount of change. If you take them from the public sector, and you take them from large-scale trials with privately hired community health workers, both have comparable benefit, but one is more than the other. Public sector staff are generally not the same as research staff. So you see benefits which are a little less, but 14% reduction in neonatal mortality, I would take any time. So in order to see this, does the opportunity of working with community health workers give us a hope for improving neonatal mortality in Pakistan? We looked at this in the real health system through an intervention that we have just finished, and I had the great honor of presenting this to the Honorable Former Minister last year in December. So this Umeed-e-Nau project that has taken me something like 6 years to finish, I will try and finish as soon as I can, was implemented in 8 districts of Pakistan. And these were the highest mortality districts, selected deliberately in collaboration with the government. And they represented 12 million population. And the impact of this, and this was largely implemented through the Lady Health Workers Program. And in these 12 districts, we've seen mortality reduction in both perinatal mortality and newborn mortality in excess of 30%. And if you look at this in terms of secular trends of reduction of mortality, these represent close to around 2 to 3 folds higher or faster rate of reduction of mortality compared to others. So yes, it can be done. But let's now, if there is time available, look at what are the common pitfalls in these approaches to address inequities. Is this the only solution? And there are several things in here that people talk about. And these are the 4 major pitfalls or constraints that people talk about. That this task shifting will be everything, and that is what's happened in Pakistan, that we started the Lady Health Workers Program with a 15-year target, and today, after 30 years plus, this is still the backbone of our primary health care. So, this is one of the biggest injustices in Pakistan. If you're poor and live in a rural area, your only opportunity of accessing care is through a lady health worker. And if you're rich and happen to be in an urban area, you can go to any physician that you like. And there has been very little recognition, unlike our neighbor in Afghanistan, that this has to change over time. So let's look at these first 2 things. So in Umeed-e-Nau, the project that I've just told you, there is very clear evidence that lady health workers do make a difference in terms of reduction in not only mortality but improvement in coverage. But they are not the only ones. We only factor in there. We also very clearly see that distance to a health facility matters. And those who are more than 50 kilometers away from a referral facility generally have the least increase in coverage. And that tells us that in rural areas, distance is a very big measure. And then there is something called inverse equity, which means that the relatively rich in these poor populations actually benefit more than the very poorest. Why? Because they also have access. And you see that for a lot of these coverages, that the people who benefited most were the relatively rich in those areas. Now, that can only change when you increase coverage level to 90% and above. So you have to be cognizant that even when you go to rural areas, you don't reach the poorest of the poor until you actually focus on the very poor. And that the final point I want to make on this context is that even within our districts, there are differences in mortality. This is the district of Badin. This is when we started off, and this shows you the heat map of where mortality is clustered for newborns. You can see that how after floods that increased enormously, and how post-floods with this particular intervention, we've been able to reduce that disparity within districts. Now, मेरा मकसद आपको ये बताने का very simply ये है कि these are not things that only research groups should generate. Every district government should have access to these tools and these measures to be able to see how things are improving within their districts. When I've shown these to district level people, they've said, oh yes, we understand because this particular hospital was not functioning. But they have never measured, monitored, or been accountable for an equity indicator within their districts alone. The other is when you can combine outreach and targeting. Can you combine these services and target at the same time so that you reach the poorest of the poor? And the example for this is really, again, I'm coming back to Khyber Pakhtunkhwa and other areas, are most conflict affected and insecure areas. This is where conflict is clustered in Pakistan or was, and you can therefore recognize that why it is that polio is also clustered in that area. So we were asked to see if we could do anything about it using some of the models that we had developed of community mobilization and community health workers. So we did this project, which we've just published just a few months ago, the final results of this, in 3 areas of KP, Balochistan, and the insecure parts of Karachi. And this required measuring and monitoring where unimmunized children and households were clustered. The strategy was very simple: through community mobilization, using religious leaders where they were possible to provide mobilization, community health workers. And the results were fantastic, better than what we imagined for immunization coverage. Look at what happened to full immunization rates in these areas. These were the worst of areas where full immunization rates went up enormously. But also importantly, look at what happened to inequities, the differences between the rich and the poor in terms of access to immunizations. This was the baseline in these 3 areas, and this is where we ended up at the end line. And particularly in the insecure areas of Karachi, inequities virtually disappeared. The last thing I want to talk about is something which is a political hot potato, which is basically universal health coverage and universal health insurance. Some of you may have seen stuff around this. The government introduced universal health insurance as a panacea without realizing that it's only one part of the universal health coverage. So universal health coverage, to this audience, maybe you are aware of it, but if you're not, has 2 principles of access and financial protection. And that is the principle in universal health coverage, and it's generally represented by this concept, that if you have an opportunity in a population of a given resource for health, you can increase the coverage of the population, give it to more people. You can also reduce the costs so people don't have the same expenditures that they have for a given health service. And you can also increase the quality and the reach of service delivery. And this is the major reason why people introduced several strategies. And one of those strategies was the universal health insurance, the Sehat card that was introduced in KP. A lot of people have maligned it. A lot of people have looked at it. Our academic unit evaluated the Sehat Sahulat card from Aga Khan University, Samin Siddiqui. I'm very grateful that he shared some of the results from this third-party evaluation. And very simply, this intervention did reduce disparities, did reduce catastrophic expenditures amongst Sehat card users, and also was able to reduce so-called catastrophic expenditures in the poorest. As you can see in the non-users, 46% had catastrophic expenditures. In the users, it was much less. And of course, the big downside of this was a lot of this was in the private sector. So just to finish, health insurance alone is not enough for universal health coverage. You have to combine it with evidence-based, cost-effective packages of care. What do you need to do? Provide them at quality, shift tasks to ancillary health professionals and others where you are not going to be able to reach, engage the community, and importantly, improve quality. So, Professor Akram, how can the Society of Physicians Internal Medicine of Pakistan contribute to this? And these are generic, but they are true for any body of professionals. First of all, by realizing that the solutions to all of these problems are not going to come from outside. That these solutions are very much internal. They are within our grasp. Jis din hum chahenge, theek karna us din hum kar sakte hain. And there are three principles that you have to keep in mind in terms of addressing this at population level to reduce disparities. First of all, equitable access and affordable health services are a fundamental human right. They need to be enshrined in each and every party manifesto as well as in our constitution. We need to do the right things, but we need to also do them the right way. So it's not just enough to have the evidence-based interventions. You need to have the delivery strategies, the platforms through which you can deliver them at scale to the right people. And we need to be advocates. My biggest frustration in all of this, I mean, I have been working in Pakistan 40 years now. I came back as a young man in 1985. My biggest frustration in all of this work has always been the lack of engagement of our intelligentsia and our physician community with health policy. Or agar engagement hoti bhi hai, even if we do engage, we engage at the level of tertiary care or in the level of urban centers, not at the level of population-based care. Because at the end, we are accountable for population-based care. And I think this will never change until we all become advocates for equitable access of services. I'm talking about maternal child health today. I can guarantee you this is true for elderly care, this is true for NCDs, this is true for adult health care. Every aspect that I've told you, some of the biggest equity gaps in this country are around surgery, the access to adequate surgery. We need the money, we need the financial protection, and we need the partnerships. Just like I've made the effort to come to your meeting, we need these collaborations across platforms to address the social determinants of health. So I want to leave you with one observation that Kaisar Bengali made 20 years ago. And it seared itself into my brain. That's why I cite it very often. I hope you know who Kaisar Bengali is. He's an intellectual, a health economist in Pakistan. And Kaisar said at that time, he was using inequality, he said, unequal societies are unjust societies. And unjust societies lose their moral and political legitimacy. While poverty causes hardship and deprivation for those who are caught in the poverty web, inequality promotes a sense of grievance and injustice, promotes despondency and anger, and generates social and political instability and even violence. I want you to think about this statement with what we face today in Pakistan, with militancy, insecurity, and a young population that is rebelling in many parts of the country. Why? Because some of the social determinants or injustices are in our face. Thank you very much for the opportunity to talk to you.